Welcome back to Midnight Med. This video is on rheumatic fever. Rheumatic fever is a non-suppurative complication that occurs 2 to 4 weeks following group A streptococcus infection. Usually this is pharyngitis, so a sore throat. A non-suppurative complication means that it is not directly related to the infection with pus or abscess formation. Instead, the pathophysiology is across antibody reaction. So the antibodies initially made to fight against the group A strep infection then reacts against normal tissue causing symptoms that we will discuss. But risk factors include being indigenous, overcrowding, which is a good risk factor for any infectious disease, as it can be difficult to control infections if everyone's close together and not isolating, as well as a personal or family history. Clinical presentation commonly is an arthritis is the earliest symptom, and this can be a migratory polyarthritis affecting the large joints. So we're thinking knees, elbows, and hands. If the heart is affected, this is rheumatic heart disease, and this is carditis or valvulitis. So carditis can be pancarditis, so it can affect any layer of the heart. Pericarditis is the pericardium, epicarditis, myocarditis, or endocarditis. Valvulitis is when the heart valves are affected. There can also be skin manifestations, so subcutaneous nodules are firm and painless, as shown here, as well as erythema marginatum, which is a rash on the trunk, also shown here. Syndrome chorea is non-rhythmic, involuntary movements, so they're really jerky. It's not a seizure because they'll be conscious and aware of what's happening, but jerky, involuntary, non-rhythmic movements. This can be dangerous because they can make weird movements and hurt themselves. They can have fractures because they're not, controlling the speed of where their limbs are moving. Diagnosis is based on the Jones criteria. So remember the pathophysiology, it's following a group A strep infection. So there can be evidence of previous group A streptococcus infection, and for this you do a throat swab for rapid streptococcal antigens. However, remember this is 2 to 4 weeks after the infection, so this may be negative if the infection has already totally been cleared. You can also do anti-streptococcal serology, so the main antibodies are anti-streptolysin O titer and anti-deoxyribonuclease B titer. Remember our symptoms, so we talked about carditis and valvulitis, so you can look for cardiac involvement. ECG changes include a prolonged PR and notably an echocardiogram as shown here, where you're looking at the valve, any valvulitis, any vegetations, or ventricular dysfunction. So especially if there's myocarditis, the heart will be contracting as it should be. And any pericarditis, inflammation of the pericardium, any tamponade. You can also think about laboratory investigation, so raise CRP and ESR being your main inflammatory markers, as well as leukocytosis. Management, so you want to clear the infection if it hasn't already been cleared, as well as provide supportive management for the clinical presentation. So definitive is benzathine benzopenicillin, so as this can be targeted against group strep A, and supportive, remember it's an antibody reaction, so it's an inflammatory process. So use anti-inflammatories or immunosuppressants, commonly steroids, and once you reduce the inflammation, you'll reduce the symptoms. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.